Guys, so this lecture is going to focus on mobility, immobility, and all the things that immobility can cause to go wrong for a patient. So mobility is the freedom and independence and purposeful movement. It's the ability to adapt to the environment and the awareness you have of that adaptation. In order to have mobility, you have to have a working musculoskeletal system and your nervous system, and they have to be working together. If they're not working together, it's going to limit your mobility and put you at higher risk for some immobility related um, comorbidities. So, immobility is that inability to move freely. The complication risks increase as it gets worse. And we're really focusing on promoting that venous return so we don't end up with a huge complication like a pulmonary embolus that can be life threatening. Goals of care are preserving, maintaining, and restoring that function. So, we're going to work side by side with other professions to get that function back as much as we can. Just a review of the musculoskeletal system. We've got our bones, joints, tendons, cartilage, ligaments. Then we got the skeletal muscle. We've got our synovial joints that have those fluid-filled sacs that are helping to cushion the joint. That's probably going to be your hip, your knees, your elbows, your shoulders, any of those joints that move in more than a couple of planes. And then your skeletal system functions are more than just that body support and movement. You've got your organ protection, blood cell production occurs in the red bone marrow, um, and the mineral storage. Your bones are a huge storage area for phosphorus and for calcium, so it's really important that we maintain good musculoskeletal health in order to have all of those functions occurring the way that they should. Nervous system overview. Nervous system has the central nervous system, that's your brain and spinal cord, peripheral nerves that coordinate your muscle movement. Nerve signals from the spinal cord cause that muscle contraction, which is the pulling against the bones to help you move. Sensory receptors are what are sending feedback to the brain, enabling that proprioception so you know where you are in relation to everything around you, and your balance for fine-tuned movement. Proper body mechanics are essential in nursing. One of the number one reasons that nurses leave the field is that they can no longer work due to injury. So it's really important we combine those musculoskeletal and nervous system efforts, maintain posture, alignment, and balance. Um, like I said, healthcare workers are at high risk. Assistive equipment or proper technique limits injury. There are some hospitals that are going to no lift hospitals. You do not lift any patient for any reason without mechanical assistance. And then the key principles of body mechanics are alignment, balance, and controlling those body movements to reduce the stress on your joints. Alignment is just your posture. It's like taking a string and putting it through the center of the body, holding yourself straight up. Balance is maintained by the low center of gravity and a wide base of support. The further out your legs are, the more of a base of support you have, and the lower your center of gravity, you're less likely to get injured. And then we're going to avoid reaching, bending, twisting, and we're going to do a lot more pivoting and bending our knees. We're using our legs for lifting those big, strong quadricep muscles and hamstrings instead of the muscles of the lower. Ergonomics just studies those body mechanics in relation to our work environment. It's the proper positioning of your hands to prevent carpal tunnel syndrome. I've seen nurses coming in when I'm working in primary care who are struggling because they've been using their thumbs to pop those pills out of pill packets in nursing homes. That is a really good way to damage that basal joint in your thumb and get basal joint arthritis. So the more things we can do using an ergonomic technique, the better off we are to decrease those injuries. And that includes having our chairs at a proper level that we are not leaning our neck. We're not putting our phone in the crook of our neck and holding it with our shoulder. We're using those proper mechanics to help avoid injury. So when we're immobile, bones lose mass, density, and strength. This is how you get that disuse osteoporosis. It's going to increase the fragility of the bones. So when we do get them up and moving again, they're going to be at higher risk of fracture after any falls. With any fracture of the hip, 80% of those patients are going to go on and pass away within 8 years of that hip fracture. So it's really important that we prevent fracture as much as possible and get that bone mass where it needs to be. Your muscles are going to atrophy. They become smaller and weaker. This is also known as sarcopenia. Leads to poor coordination, reduced activities of daily living. The larger the muscle group, the more quickly they are going to atrophy. And then the joints get stiff and decrease in range of motion. We can develop contractures. That's when you cannot move that joint anymore. This is why passive range of motion activities are so essential with our patients that are immobile. Cardiovascular wise, the fluid redistribution occurs within 24 hours of laying in bed. So we're going to have temporarily increased cardiac volume, diuresis, and reducing that circulating blood volume. When you are laying in bed, your body is shunting all the blood away from your legs. So when you're doing that, your body starts to think that it is in overload and it starts to try to reduce that circulating blood volume because it will eventually increase your blood pressure. This is how we end up with orthostatic hypotension, that drop in blood pressure when we stand up, because we've done everything we can as a body to reduce our blood pressure so that we can keep everything perfusing the way it's supposed to. And we actually didn't have that extra blood volume. So now we stand up and our blood volume goes all over and we get very dizzy, lightheaded, and can potentially have a serious fall. Uh, there's also increased of deep vein thrombosis that comes along with it. When we get to the gastrointestinal effects, we get decreased appetite, our caloric intake decreases. We end up with nutritional deficiencies. Any deficiencies are going to lead to potential issues going down the road. A decrease in calcium intake combined with that immobility is going to decrease our bone density. Peristalsis is going to slow. This is exacerbated by opioids and the lack of gravity. So now we're ending up with more constipation, which is making us less likely to eat, which is going to result in more constipation. It's a never ending cycle. We get that fecal impaction risk. There is a decreased urge to defecate when you are laying down because you're not getting that pressure from above. And then GERD may occur because fluids are accumulating due to that backup of fluid and lack of peristalsis. So there's a lot more pressure on the lower esophageal sphincter. It opens up, and now we've got heartburn. Genitourinary wise, laying supine increases the risk of your bladder not emptying fully. Think of it as a balloon with a string. We turn that balloon on the side, the string is no longer hanging straight down, so we're ending up with fluid staying stuck right in the sides of that balloon. Incomplete drainage leads to kidney stones. It can lead to urinary tract infections because that urine is just sitting there festering. The bladder can get overdistended because we're retaining the fluid and damage the bladder lining, which can increase the infection risk. And the damage to the bladder lining, if it's significant enough, can lead to a urinary cancer. Immobility increases the pressure on skin areas that are in contact with surfaces, specifically those bony prominences, the greater trochanters on the sides of each hip, the sacrum, the shoulder blades, the back of the head, the heels. Any skin that's exposed to moisture gets at an even higher risk of breakdown, so we want to keep the skin dry. And then pressure injuries are those localized damage or necrosis to the skin and underlying tissue. It's caused by that pressure and then the shear from pulling somebody up in bed without lifting. When you do that, you are pulling the skin up or the body up, but the skin is staying behind. So you're increasing the likelihood of having that necrosis to the skin. So whenever we move somebody up in bed, we're going to tilt the head of the bed down, put them in Trendelenburg. We're going to lift and pull up. We're not going to slide. This is where draw sheets are essential. The psychological impact. The less mobile somebody is, the more likely they are to become depressed because they're being reliant on other people for their activities of daily living and their independent activities of daily living, like just being able to go to the grocery store. They get a negative impact on their self concept, self esteem. They increase anxiety, depression, frustration, and then they can become more socially isolated. If they're not getting out of their room in the hospital or in the nursing home and going out to activities, they become further and further isolated and decrease in their emotional well being, which can lead to untimely death. So any alterations to muscle function, injury to the musculoskeletal system, like those fractured hips, poor posture can impair the central nervous system. Underlying health status, the age can impact mobility. Immobility can be temporary or permanent, and it can be sudden or gradual. You can get sudden, permanent immobility from diving into a pool head first and getting those spinal cord injuries. You can get gradual immobility that's temporary from having something like polio. You can have permanent, gradual immobility from multiple sclerosis. There's a lot of diseases that can cause immobility, and it's important that we recognize when those factors start to take place and do what we can to help maintain that function. So, in summary, integumentary wise, we've got that increased pressure, decreased circulation, leading to ischemia and a lot of pressure injury. Respiratory, we get stasis of secretions, decreased muscle function. They get that atelectasis, which is the incomplete opening of their lungs. And then they can get a hypostatic pneumonia. So we're doing a lot of coughing, deep breathing, working with those incentive spirometers where you are not using it to breathe out as quickly as possible to get that ball as high in the air as you can. You're actually trying to breathe in as sustained as possible to get that ball where it needs to be. The ball should actually be in the smiley face zone while we're getting that lung capacity up. Cardiovascular, you've got that orthostatic hypotension. Blood starts to get have stasis in the legs. You got decreased cardiac output, and then you are at higher risk for thrombus if the blood return is not coming from the legs. That's why we do a lot of those little ankle pumps where we're moving those ankles. The more we move the muscles, the more pressure there is on the valves to open up and allow that blood to come back through. Metabolic and elimination, they're going to decrease their metabolic rate. They're going to have decreased appetite. Calcium's going to get reabsorbed into the blood instead of into the bones. So they're going to have muscle atrophy, decreased stability, contractures, foot drop. And then neurologically, they have that ineffective coping and the anxiety, depression, and social isolation. Each age can impact differently. Infants, toddlers, and preschoolers are going to have slower gross muscle skills, and they will have unbalanced posture if they're immobile for a long time. Adolescents might have delayed independence and social isolation. It's occurring a lot less nowadays because it's a lot less you're a lot less likely to be ostracized for having some sort of mobility issue. Kids are a lot more understanding than they used to be. I can't say that they're completely understanding, but they're a lot better than they used to be. Um, Adults, they're going to have alterations in their family and social systems and job identity and their self-esteem. If you've got somebody whose job is very, very active and now they're immobile, they're not going to have a good part of their identity, and we need to find ways to help them cope with that. And then older adults, they have that balance issue, bone mass loss, decreased coordination, slower gaits. They become more and more dependent. So we have to really look at the age in order to help determine what they may need help with. So our goal for skincare, maintain that skin integrity, prevent those pressure injuries. We're going to observe for breakdown, warmth, color changes. We're going to look at all the bony prominences. We're going to try to pad them if we can. We're turning every couple hours. We're looking at skin turgor, incontinence. We're using those risk scales like the Braden pressure injury scale. We're doing all the things that we can to help prevent those injuries. And there are therapeutic beds we can use. There's a sand bed that has a lot less pressure. We can use egg crate mattresses that help to relieve the pressure. And we want to make sure we're encouraging a lot of protein because low albumin levels in the blood, which is a type of protein, can lead to decreased skin integrity. Respiratory, we want to keep those lungs going up. So every 2 hours, we're going to take a look and make sure their chest wall is moving. We're going to listen to their lungs for adventitious sounds. That just means anything that's not supposed to be there. Check if they have a productive cough. We're going to look at the color, amount, consistency, and we're going to document that consistently. There is no evidence that green sputum is worse than clear sputum. But if you had clear sputum yesterday and you have green sputum today, now we may have an issue. So the color is not the most important thing. It's whether it's changed in color, amount, and consistency. And we're going to reposition. We're going to use the incentive spirometers. We're going to do chest physiotherapy, which is just forming a cup with your hand and hitting the back of the patient to help get those secretions loosened up. We're going to educate them on turning, coughing, deep breathing, making sure they're hydrated. If they're dehydrated, those secretions are going to get a lot thicker. So just different ways that we can keep that respiratory system intact and avoid those pneumonias. Cardiovascular. We want to increase their activity tolerance and prevent clots. Prevention of clots is the most important cardiovascular care in immobility. So we want to assess orthostatic blood pressures. What you're going to do with those is you're going to lay a patient flat for 3 to 5 minutes. After they've laid for 3 to 5 minutes, you're going to take their blood pressure and pulse. Then you're going to sit them up, take their blood pressure and pulse, make sure they're not dizzy. If they're dizzy, let them lay back down. It's okay not to get a reading because patient safety is paramount. Once they've sat back up, we're going to get that blood pressure and pulse. Then they stand up after about a minute or two. Then we're going to get their blood pressure and pulse again. Again, if they're dizzy, we lay them back down. We're going to look for edema and warmth. We're going to look for DVTs. You're going to have that redness, warmth, tenderness. The best practice is to measure calf circumference every day. If there's a major difference in the size of the calves, like one day they're 15 and 16 and the next day they're 15 and 20, we know we've got a problem that needs to be reported to the doctor. So measuring that calf circumference is a great way to watch for DVTs. Nursing actions, we're going to dangle their feet. We're going to do frequent position changes. We're going to avoid that valsalva, which is the stimulation of the vagus nerve that can cause bradycardia, by using stool softeners, making sure they're not getting constipated. We're going to do range of motion and ankle pumps to prevent DVTs. Use our sequential compression devices if they're ordered. Anticoagulants like heparin and Lovenox if they're ordered, and educate on those isometric exercises or to just those ankle pumps, ankle rotations, anything we can do to get those legs moving to keep that blood circulating. Metabolic care, we're going to reduce skin injury and maintain their metabolism. We're going to record the anthropomorphic data. That's just a fancy way of saying their height, weight, and BMI. We're going to assess what they're eating. We're going to monitor what they're eating, monitor that they're urinating, that they're having bowel movements, monitor for wound healing if they already have a wound. And we're going to review their electrolytes, protein, and BUN levels in their labs. Nurses can provide high calorie, high protein diets with supplements as ordered and monitor that oral intake carefully. If you're unsure what a patient's dietary needs are, ask for a referral to a dietitian. They are a fabulous resource that can come in and do a lot of that teaching and education on high protein diets. Elimination, we just want to maintain it. We're going to keep track of their intake and output. We're going to look for bladder distension. Using a bladder scanner is a nursing intervention that we can do. If the urine in the bladder is more than about 400 milliliters, we're going to call the doctor and say, hey, what do you want me to do? Sometimes there'll be a policy in place. We're going to know what the policies are where we work. We're going to assess the color, amount, frequency, clarity of their urine, listen for bowel sounds, observe their feces, make sure they're having bowel movements. Maintain that hydration. Adequate hydration is essential to preventing so many different diseases and complications. We're going to teach bowel and bladder training. We'll put in a catheter if we need to, and we're going to educate on that high fiber diet. Musculoskeletal care, we're going to assess their range of motion and passive range of motion, assess their muscle tone and mass, watch for contractures, monitor their gait, make sure they're getting adequate calcium, and monitor their use of assisted devices and teach them how to use them. We want to make sure they're changing position frequently, doing their range of motion at least 2 to 3 times per day. 1 time per day is not enough to avoid contractures. Physical and occupational therapy, we're going to get them started early to promote mobility. We're going to educate the patients on how to do the range of motion, and we're going to do them every time we get them up to eat, bathe, groom, and dress. How to use a cane. Contrary to popular belief, the cane goes next to the stronger leg. We want the weaker leg to move with the cane. That is one of the most important things we have. We want the weak leg to have the cane down with it at all times. If they're on the same side, you're at high risk to fall. Proper crutch use. Crutches do not go in the axilla. Crutches should hit the next to the ribs. We want most of the weight on the crutches to be on the hands. We need our arms at 20 to 30 degrees of elbow flexion. Um, we're going to use a tripod position to sit down. And we, like I said, do not put weight on those armpits. I will be posting a video of how to teach patients to ambulate with crutches and all the different crutch gaits. But just as a brief, we have the 4-point gait, which has weight bearing on both legs, and we're going to alternate each leg with the opposite crutch. It's just like walking and swinging your arms. 3-point gait, we're going to bear weight on the non-affected foot while using both crutches. The affected leg never bears weight. And the 2-point gait, partial weight bearing on both feet, and we're going to move the crutch with the opposite leg simultaneously. Using a walker. We want the walker height so that the patient's elbows are flexed at 15 to 30 degrees. We want them to move the walker forward about a half a foot, support the body weight, advance a foot, and then the other. This is for your standard walker. For the rolling walker, like the lady is using in the picture right there, they're just going to ambulate normally while pushing that walker ahead of them. What we want to make sure they do, though, is if they're going to stop and sit or stop to do anything, we want them to hit those brakes so it doesn't go flying away from them, cause them to fall. Psychosocial care. We want to maintain their sleep-wake patterns. We don't want them waking up at 1 o'clock in the afternoon and going to bed at 1 o'clock in the morning. We want to try and keep it as normal as possible for them. We want to encourage that independence and socialization. So we're going to keep an eye on their emotional and mental status, monitor their sleeping, ask the doctor for something for sleep if we need to, and we're going to get the family in there to help support them emotionally. We're going to give them things to help keep them awake during the day. TV, crossword puzzles. We're going to give them a semi-private room if it's appropriate with an alert and oriented patient that they may be able to chat with. And we're going to recommend consultations as often as possible. Chaplaincy is a great consultation. It's important that we tell the patients that they are non-denominational. They are not going to come in and try to get you to switch to any particular religion. Their job is your spiritual needs overall, which in some cases, spiritual needs are just your emotional needs. They understand that not everybody believes the same way, and they're not there to try to tell you that there's a right way. Heat versus cold. It's important to remember that heat and cold therapy require a medical order. We cannot just go get a patient a heat pack because they ask for one. It has to have a provider order. And that's because you can cause significant burns or cold, cause frostbite. So we need to have the provider order and it needs to have specific parameters. How often, how long, and what kind. With both heat and cold, there is moist and dry. Dry heat is more likely to cause burns and be bad for the skin than a moist heat. Heat is really great for chronic pain and muscle spasms. It helps to relax the muscles, increase the blood flow to the area, and really get a pain relief. Cold therapy is great for an initial injury because it decreases inflammation, prevents swelling, reduces that bleeding, and it slows nerve conduction and it's going to constrict those blood vessels and not allow as many inflammatory markers to get there. What we want to remember is that for the two types of arthritis, rheumatoid arthritis is an inflammatory disease. We are not going to want to put heat on it because it will trigger those inflammatory markers. We are going to want to use cold only on rheumatoid. Osteo can use either. So we're going to apply it to the area, make sure the patient has their call light, and to report anything that feels off immediately. We're going to go back every 5 to 10 minutes to look for any signs of burning, blistering, cyanosis, anything that could be causing damage to the skin. We're going to always have some sort of cloth in between the patient and the source. And we're going to discontinue it if there's any side effects or at the end of the prescribed time, which is about 15 to 30 minutes. Usually it's about 20. When we're documenting the location, the type of heat or cold, the length of application. What did the skin look like before? What did the skin look like after? Did the patient tolerate it well? And like I said, it always has to have a prescription. Promoting venous return, we've got those anti-embolic stockings. Those do require a prescription because if the ankle brachial index is not correct, you can cause damage. That's not important for you to know at this juncture, but just know the anti-embolic stockings must have a prescription. They're going to provide that external pressure and help open the valves and get that blood back up to the heart. Sequential compression devices, they're sleeves that go around the leg and they just inflate and deflate the sleeve to help promote that blood turn. Again, another prescription is required. The only thing we can do that does not require a prescription is repositioning, avoiding or letting patients cross their legs because that will cut off the circulation, and doing those range of motion exercises. Those are the only nursing interventions to promote venous return. We cannot use any kind of stocking, sequential compression device, or medication without a medical order. So thrombophlebitis is that inflammation of the veins. Um, it's going to be just a discomfort and it can result in those clots. Things you're going to see with thrombophlebitis are pain, edema, warmth, and redness in the affected area. When we're assessing, we're doing bilateral calf and thigh circumferences daily. We want to make sure they're not increasing in size. Homan's sign is a pushing of or a dorsiflexion of the ankle that used to be used to determine if there was a DVT, but it is not specific, so we are no longer using it. You may still see nurses do this. If we notice anything off, we're notifying the provider immediately, elevating the patient's leg, not massaging or rubbing it. If you massage or rub a deep vein thrombosis, you are very likely to have it break off and go to the lungs. So we are telling the patient, do not massage it. I know it may make it feel better, but it's going to be worse in the long run. And then we're going to anticipate the patient starting out anticoagulation therapy and labs needing to be drawn from them. Pulmonary embolus is that potentially life-threatening occlusion of blood flow to one or both of the pulmonary arteries by a clot. And those clots generally are starting in the lower extremities with the DVT. We're going to have sudden shortness of breath, chest pain. The chest pain is going to be pleuritic, where it hurts more when they breathe in. They may be coughing up blood or blood-tinged sputum. Their blood pressure may tank. They may become tachycardic. So we are going to be prepared to give anticoagulants and send the patient to CAT scan if they are stable. If they are not stable, it's likely the provider will just automatically provide an anticoagulant to get them stable. If they are unstable, they are very likely to go to the ICU for a higher level of care. We're going to put them in a high Fowler's position. High Fowler's is 90 degrees. We want to get those lungs inflating as much as possible. We're going to get a pulse oximetry, we're going to give them oxygen, and we're going to keep a very close eye on these patients.